Hello, everyone. Welcome back. I am so excited. Today, we are going to be talking about vestibular neuritis, and I have the lovely, my favorite human, Dr. Jenna, with me. So, we're going to talk about neuritis, what it is, and what to do about it, and if it goes away, and all fun things. I actually just saw someone this week with vestibular neuritis here in Jackson, which was a fun thing that I don't usually see. Not fun for her, but she's doing great.
Yeah, I don't know. I feel like when we were both doing our vestibular clinicals at some point as we were learning more, I feel like we definitely had a conversation of like, if I had to pick one, what would I do? And
BPPV.
I think I picked this one because I was like, I don't know if I could deal with BPPV, but I guess if you get this, you could still get BPPV. So
That's true. That is true. I have had BPPV once. Do you know that about me?
yeah,
I've had it once. Yeah. It was interesting. I won't say if it was fun, but it was fun for me in like some maybe
like out of
sadistic
body
way.
observer
Like,
experience.
yeah, it's like, oh, I know what this feels like now. Exactly. Exactly. But yeah, vestibular neuritis, everyone should know at first that this gets better. Vestibular neuritis, like people do really well with neuritis. And if you're a person who's had vestibular neuritis and you're like, this has been going on for years and like truly I feel like it's never gone away, let's talk about why that might happen. And we can get into that a little bit later. But vestibular neuritis overall, very good outcomes.
Yes. And I know I think that's part of why I was like, let me pick that one if I had to pick one, because in theory, it's super, super rare for it to happen again. The like thing that happened, that
Mhm.
nerve inflammation from like a viral infection that happens, like it's like a one time thing. And then our brains are nice, smart organs, and it learns and adapts and wants to move forward from it.
Totally, totally. And when I was texting the patient this week who has vestibular neuritis, and she's asking me, she's like, "Does this get better? What does the timeline look like?" All those different things. And I told her, I was like, "Oh yeah, like people get better from vestibular neuritis. The timeline is definitely a couple of weeks, but like the more you move, the less you panic about it. The more you allow your body to be like, hey, I'm safe, I'm okay. Like I just had this infection, didn't feel great, not comfortable. I was spinning, I was super dizzy, and I still am super dizzy. But the more that we move our bodies and stay relatively calm, the better you feel in a shorter amount of time. And that's not to say for people who I know are going to say, well, I don't feel better and I don't feel calm and I've been dizzy for years because of neuritis. We can talk about kind of what to do about that too. But yeah, I'm totally with you.
Yeah, I was gonna say, like, I feel like vestibular neuritis can be like BPPV sometimes, where there's like the superstars, like, I got better in one treatment, or I was better in 3 weeks, and I don't have any issues ever thereafter. And like, those are the stories that everyone wants to hear, but then it makes you feel bad if you're not exactly on their timeline either. So I have had people
Totally.
that have had a neuritis, and maybe there's these like certain instances, or just these, they're like, I'm 99% better, but here's this like 1% stuff that's still just kind of nagging at me.
Absolutely. Absolutely. Okay. So, what exactly is a neuritis? I guess we should start there, right? Like, what exactly is it and why does it happen?
Yes. When I was writing this down for an outline, I was like, oh, I'm getting way ahead of myself because I started getting more into a hypofunction. So, a neuritis itself is that inflammation of the nerve. So, neuritis, itis, inflamed, nerve, nerve. So, neuritis, inflamed
Hmm.
nerve. And it's that cranial nerve 8, the vestibular cochlear nerve. So, it impacts the way that nerve is able to send information between the inner ear and the brain. And this
Exactly.
just changes up the messaging system that it's used to. So I think of it as like you're learning a language. I always think of like you added a 27th letter to the English alphabet or something, and now you're trying to figure out how these words are supposed to be. So it can really throw your body for a loop, but you can learn how to understand those messages again.
It's like the S's and the F's you mentioned a couple podcasts ago of like if you switched all the S's and the F's in all of the books and tried to read it, like you'd get used to it over time, but it'd be hard. And a lot of people compare this kind of like, I feel like I had a stroke, even though you definitely did not with neuritis. It was not a stroke. But a lot of people say, like, I feel like I'm recovering from something similar because my brain just isn't working the same way as it used to, but my brain's going to learn how to work that way again. And rehab is your friend here after the acute phase. And when you get that viral infection, typically it comes from the herpes virus, which most of us have herpes floating around in our body somewhere and it just doesn't do anything. It's the same virus that causes cold sores. It can cause what you think of as herpes. It can cause what I
Chickenpox,
always
right?
keep saying, yeah, I keep saying strep throat, but I mean chickenpox, like, which doesn't make sense. Chickenpox and shingles. So all of these things are versions of the herpes virus, or just different ones. And it will just be kind of floating around in your body. And typically people will get like a little bit sick, a little bit of a cold, their immune system goes down. And then that virus just like takes that moment and says, you know what, today's the day I'm going to infect that nerve. And when it starts to send that signal, it starts to say like, hey, we don't have function in this ear anymore. And, or we have only some function in this ear. And that's when our body starts to say like, okay, now we feel like we're spinning.
Yes, and I think it's because those like herpes it like lays dormant in nerves, right? Because that's
Exactly.
how shingles tends to present
Hmm.
too.
Hmm.
And I know sometimes people, yeah, they notice that they're sick. Other times they might just be like, I felt fine, but then this suddenly happened. And that can happen with like shingles too, right? So maybe you were just tired, fatigued, maybe a little worn down, but not in
Hmm.
a feeling sick sense, but you're something about that virus saw an opportunity and took it.
Exactly. And your brain interprets like this inflammation as now we are moving. If you remember in the podcast we did, probably I did like second, we did like anatomy and physiology of the vestibular system. I think it was actually first. And in that, we talk about how like you have two vestibular systems, one on each side, and they fire looking forward all the time. When you look to the right, the right one fires more. When you look to the left one fires more. And so if one has an inhibition signal, that by proxy makes it seem like the other one is firing more. So it acts as if you are turning your head one way. So if you have a neuritis on the left, it seems or appears to your brain that you are firing more to the right, which is going to make your eyes turn that way, which is what causes the involuntary eye movement or the nystagmus. And it makes you just feel like you're moving.
Yes, that one was always a hard one to wrap my brain around at first.
Okie doke. We just had a weird technical glitch when talking about neuritis. As we were saying, I think we were talking about comparing brain signals left and right.
Yes, because I think I was
Okay.
like, this was like a really hard one for me to like conceptualize at first. And I think I know people like to use like the seesaw analogy where when
Mhm.
one goes down, the other goes up in equal amounts, like someone on a
Mhm.
teeter totter. And then once that nerve inflammation happens, it changes that signal. It's like you took a person off the seesaw. So now it's constantly off now. And your brain's just taking that information and doing what it would normally do. And that's when it starts learning that, hey, wait, this isn't right. It's not working like it used to.
Mhm. Totally. And it's an interesting thing because again, your brain will start to adjust to this when it's given the right signals. It's going to start to learn like, oh, this is our new normal. So like if you're watching this, like my right side is at a hypofunction. Okay, this is my new normal and this is what looking straight actually feels like now, rather than it being like this before. It's like this now and this is my new, okay, I'm straight dead ahead on. Um and so that comparison at first is high low, and then after that it will start to your brain will start to understand kind of where it's coming from.
Yeah. I think you ride bikes. You have a mountain bike.
I have a mountain bike.
So the
You're bigger
importance
bikes
of
than me.
keeping your handlebars on a bike straight, right?
Uh-huh.
Is important so you can ride correctly. But if, say, someone loosened the handlebars and just like turned them a little
Mhm.
bit and then retightened them, you're gonna try to make them straight. And now all of a
Mhm.
sudden you're turning, and now you got to learn, oh, I actually have to hold this at a slight angle now in order to go
Yes.
straight. So I like to think of it as maybe you don't have a properly aligned handlebar, or maybe an old car where it's like, gosh, like I think I'm holding it straight, but I feel like I'm
Yeah.
veering now. So now I need to adjust. So that's what your brain's trying to do in real time, but it's with every type of movement imaginable, not just driving straight down a road. It's turning, twisting, bending, laying down, sitting up. So it's having to readjust to a lot more movements.
Totally. And the more you move and say like, hey, I'm safe, brain will start to understand like, oh, this is safe, this is okay, and I can do this. I have to keep it my cord was a good idea. Hold on. Okay.
I was like, you froze for like a minute, but
the technology issues today are on one.
Doesn't like the cold weather.
I'm having the weirdest morning, honestly, you guys, like the strangest morning. We don't have time to talk about it because I have a patient in about 19 minutes, but I'm having a bizarre morning. Jenna knows. Anyways, so when you get a neuritis, what exactly happens? Like the typical course of a neuritis, people usually, this is where people get confused sometimes, of you will have a severe onset of dizziness and vertigo. Typically, it's room spinning. So, like, the room will spin and spin and spin and spin and spin for a couple of days. But I've also had people say, like, the room didn't spin, but I just woke up one morning and everything, like, internally was pretty spinny. But then they'll go get an MRI and, like, they see all this inflammation and then they'll get a steroid taper or whatever. But typically, what we'll have, we don't have a VNG here. So, where I live. But it's typical that you would get some like room spinning vertigo type of sensations and then kind of going from there. It should start to get better.
Yes, and that's the big thing, is it's really intense, could be hours, maybe even a few days, but the general trend is it gets better with time after that initial like, whoa, this is super, super severe and intense. Usually at that point, if we're seeing people more acute, they might still have more of that like, spinning feelings or even like some nausea with it. But if it's later on, they might not notice as much dizziness, but I just feel off balance. Like I feel like everything's bouncing, like turning movements. Like I don't dare move my head while I'm walking or doing something else because I just know I'm going to be reaching my hands out trying to grab for something to steady myself.
For sure. And some people start to feel okay, but the thing about neuritis and how you know you don't have neuritis over time is that this type of attack keeps happening. So people will be like, I've had like 6 vestibular neuritis attacks. It is possible for this to happen 2 times. That's a very small chance. If this happens to you more than 2 times, you have a different diagnosis. Like it's not a thing. I will say I believe there's something called autoimmune vestibular neuritis, but like that is even more rare. And so I would even venture to guess you probably actually have vestibular migraine. So it's very, very rare to have that. I'm not saying it's impossible. I'm sure someone listening to this is going to be like, I have that. I believe you. But it's unlikely that all the people listening to this have that. And so if you keep getting recurrent neuritis-y feeling attacks, it's likely not that, especially if you go get a VNG and the VNG is like, oh, you're normal. It's like, that's not neuritis, because if you get a VNG, your neuritis will be there. I guess the exception is if you have like a pretty little neuritis at first and then you took a steroid taper in the first 72 hours, that can like almost grow back. Not grow back, that's not a good word, but it decreases like the inflammation.
Compensate quickly.
It compensate more quickly. Yeah, exactly.
Yeah.
So
I remember someone that like their VNG, they definitely had it, but by the time they were coming into PT, they're like, oh, like, yeah, it's still just kind of hanging around. And they had 2 monitors for work. So lots of like head side to side, and they really like playing video games. So they're like, that's my thing that I like to do. I was just going to like keep at it. So they were basically like rehabbing themselves by being like, I'm going to make this work for me. And they were pretty much doing what they needed to do on their own.
Totally. And that's where we really need to remember, like, doing the things that you want to do is honestly some of the best rehab that you can humanly possibly do.
Yeah, they were like, I would just take breaks when I needed to, but I wasn't going to just avoid it, which is.
And that's the perfect thing to do. Take breaks when you need to. That's like what we're all screaming and yelling about as PTs. It's like you've got to be taking breaks, and you've got to be reminding yourself, hey, I'm safe, hey, I'm okay, and then going back to the thing you want to do, because it's important.
Yeah, I think with neuritis too, potentially, like once that more like nausea type sensations are going down, I think this one just tends to be a little bit more forgiving or easier to try to push into it a little bit more. But because usually you do it, you take a break, it tends to resolve relatively fast, and then you keep pushing. But that's not the case for everyone, right? There could be other things kind of making that a little bit harder. But I think for this person, it was just like, I stop, I take a little break, I'm good to go, I go back to it. And I think this is the area where you might get a little bit luckier in that type of situation where you can kind of quote unquote push through it, but not the case for everyone.
Totally not the case for everyone. And rehab is so helpful. Like most people, not everyone, but most people will need like rehab for a couple of weeks if you can't just progress it yourself, honestly. Like the lady I was talking about at the beginning, like I saw her last week, and I probably honestly won't see her again for a couple of weeks because she understands like how to progress her exercises, and she has my number if she needs to do anything. All of my like one-on-one patients, if they need it, they can have my number. And it's, if she needs something, like yesterday, she's like, hey, I did this activity and it actually was way harder than I thought it was going to be, but I'll try it again tomorrow. But I was able to do it, was the point. It was something she thought she wasn't going to be able to do at all. And she's like, it was hard, but like I could do it, and like I'll try again tomorrow. And like that kind of a thing is like, okay, I don't need to see you twice a week. People who are in VRT twice a week for 12 weeks or whatever, I hope your insurance pays for 100% of that, because it's just not necessary. At least what we were taught, like at the clinic we learned at first, it was like, okay, maybe once a week, probably every other week, because what matters in VRT is you are doing your exercises at home. Not that like we are, unless you're a person who's like, I need to come to the clinic every day in order to do these, or I'm not going to do them. That's a different situation. So
yes, because I know sometimes it's just needing to know like, oh, I do need to get back to doing it, and it is okay. I'm not going to make things worse. Just keeping in mind that pacing, taking those breaks and checking in. And then with some of those exercises with neuritis, it's just like, here's a close variation. Maybe it's a little bit busier. Maybe it's a little bit faster, but it's not a huge shift from the exercise you're previously doing, that it can be pretty straightforward to progress on your own.
Totally. So in physical therapy, I guess the evaluation that you can expect, if we're going to be talking about that, is it's important to remember that we can only do like bedside tests rather than like your physical therapist isn't going to be doing a VNG. Like your PT isn't going to be doing the big goggles test, whatever. We usually, some of us have goggles that we can use that are like, we'll test for BPPV with, but like we generally don't use them for much else. I mean, you can check if there's like nystagmus without room light and things, but it's typical that in this, they're going to do the two most important tests that they're looking for are your dynamic visual acuity, and that's one where they shake your head really fast while you try to read the same line you read without your head moving, and then a head thrust test, which is where they put their hands on the side of their head and they move your head really slow and then fast, and really slow and then fast, and then see if your eyes stay on the target or not.
That, and of course, always that subjective hearing, what were you experiencing, what happened, to kind of put those pieces together of, is what I'm seeing matching up with what you're saying to sound like a neuritis. So if some of these tests are abnormal, like the shaking the head with the eye chart or something else, but they're saying, hey, this is happening like 6, 7, 8 times, I might be thinking, well, this might be more like Meniere's, or maybe there's more like visual vertigo with recurring migraine attacks or something. Like, these tests don't only test for neuritis, but it's letting us know that there's trouble there that is likely seen with a neuritis as well.
Absolutely. I received an email from someone and they were like, I have these symptoms and they're symptoms of every single vestibular disorder. So like, how am I supposed to know? All vestibular disorders have the same symptoms pretty much, like dizziness, vertigo, disequilibrium, feeling I'm going to fall over, feeling drunk, feeling lightheaded, feeling heavy-headed, spinning, not spinning, internal spinning. That can describe literally every single vestibular disorder. I can't think of one that that wouldn't describe. So it's not about necessarily the symptoms when you tell them, like, yes, you should tell me your symptoms, because if you're lightheaded, I'm going to treat it a little bit different than if you're spinning. But it's because they all meld together so much, it is important to see someone who actually understands dizziness disorders, because the timing and the triggers and like those types of things are what's going to help us distinguish which one it is, because that is truly what makes a difference between like Meniere's disease and neuritis, and labyrinthitis and neuritis, and Meniere's and vestibular migraine. Like these little things in between are what make or break that kind of differential diagnosis.
Yeah, definitely. When it's the vestibular organ that's kind of the center of what's going on here, it's going to have a similar reaction or symptoms in people, but what's the best way to go about managing it? So I kind of think of it like if you're cooking, you have ingredients, but they can get put together in different ways to get different meals or whatever. So, vestibular is similar to a certain degree, but making sure it's being best managed and giving you the best outcomes, that's when it's a little more important to get a better idea of those different paths.
Absolutely. And then you're going to do exercises. And we're going to prescribe them specifically. I typically don't say that like a handout online or like going on YouTube and saying like what are exercises for neuritis is a good idea. I put a video up on YouTube years ago before I understood, I think, the intricacies of like people with vestibular migraine don't always need rehab and things like that. And there are people who comment that on that video every week, like, how many reps do I do for my dizziness? And I'm like, I don't know, because the number, it's going to be different for each person. And generally, you don't need to shake your head around for 2 minutes at a time. You can generally do it for 15 seconds and then pause and do grounding. And like the clinical practice guidelines say, I should start my exercises within a week-ish of the neuritis when it's in this subacute phase. So that means it's not like we're still spinning on your internal might be spinning, but like externally the room is no longer spinning, and you are feeling like a tiny bit better, and you can move your head around a little bit, and you can do breathing and grounding and try and calm yourself down. And then these types of exercises will start to work. But gaze stability, which is where you focus on one thing and shake your head back and forth, that's really retraining your brain. Vestibular ocular reflex cancellation, or VOR cancellation, that is going to be the one where you stare at your thumbs and you spin your whole body around. It's great for motion sensitivity. Walking with head turns, full body turns, turn and scan, tracking, saccades, however you want to say it. Like all of these exercises are great for neuritis, but you shouldn't just like do them willy-nilly because you heard them on this podcast. Like some people need VOR times one. Some people need to start with tracking because anything below 120 is technically tracking and not VOR times one. And so it's like getting to these different spots is important to do with someone who knows what they're talking about.
Yeah, because I mean, just like you're needing a knee surgery, if you're going into it and you're super active, you do a lot of strength training, your recovery might look a lot different than someone that's had years of knee pain. They haven't been moving much. They just don't have a lot of baseline strength or flexibility or something, and their rehab from that's going to look different. So everyone's background gets taken into account with this. And, some people might be like, I want the standard boring ones, just have me do them and be done. And some people are like, why can I get off those and start doing things that look more like basketball or tennis, or I'm getting back into bowling? Like, how do I start making these things look more like that?
Absolutely. I think everything should be function forward. I always say that I don't care if you can shake your head and keep your eyes stable at 240 beats per minute if you can't do the things you want to do. So around here, that's like, I want to go for a really long hike. I want to skin and ski down a really huge mountain and like be aware of avalanche terrain. So I need to think really clearly. I want to be able to and when I used to live in New York, it was like, I want to ride the subway again. I want to do these things. And so making it function forward is so much more important than being able to do these standard exercises. So if you are a physical therapist and you are listening to this, I urge you to try and think outside the box when it comes to these things of, yes, I know all of the basic exercises they teach you in these classes that you learn how to do vestibular rehab, and those are super important. Like, do not discount them. but also it's important to make it salient, to make it functional, to make it matter to your patient, and patients who are listening, make it matter to you. These are the things that I want to do. I want to dance at a wedding again. How do I get to that? And we usually physical therapists are going to be able to break that down for you.
Yeah, I've had one or two that had neuritis or maybe just a hypofunction. So there's still that asymmetry. It just might have been from a different cause. And one of them, like DVA, technically normal within the testing parameters, but they were like, I want to get back to like my competitive or gosh, I don't know what I'm thinking of, like co-ed 3-person basketball league type thing. Like, so that's where I'm still noticing that it's tough. And it's like, okay, well, let's like side shuffle down this hallway, passing a ball back and forth. And they're like, that's what I'm noticing, even though their testing all looks normal. They're not, you start ramping up that intensity, you start making it what their life is, and it starts coming out.
Some things can linger. So like bumpy car rides can get hard, jumping, really fast movements. And then of course you can develop triple PD, and we don't have a ton of time to talk about this today, but we've talked about triple PD before, I think, and triple PD is more likely to be developed if you have a history of anxiety or health anxiety. If you're thinking to yourself, is this going to make me dizzy? Is that going to make me dizzy? Oh my gosh, this just made me dizzy. I'm going to be dizzy forever. And kind of the way you speak to yourself internally. Triple PD is the biopsychosocial model of it is something for a very long conversation. But if you are chronically dizzy post vestibular neuritis and you're like, this is just not going away, the neuritis has likely healed. You are left with a hypofunction. You can have hypofunction plus triple PD, or you can have a hypofunction that can turn into vestibular migraine if you have a migraine history. It can turn into secondary endolymphatic hydrops. It can make you more prone to developing BPPV. It can make you more prone to potentially developing Meniere's disease, but that is very, very rare compared to the other diagnoses. So just some things to look out for in general are important. And did you hear that a bomb exploded on the mountain next to me and it just shook this entire building? Did you hear that?
I did hear that. I just thought someone like dropped a book. I don't know.
No, that is them bombing the avalanches outside. It snowed so much last night.
Oh.
Dee just texted me that Hugo is under the bed currently, and usually we have to like deadlift one side of the bed and someone has to scoop him out. But we just got a new bed frame and it's way heavier than our old bed frame, and he's so far under there that he can't get him out. So we're just going to leave him until he feels like coming out. Poor guy. Anyways.
Nobody.
Anyways, neuritis can turn into many things, and it can leave you chronically dizzy. And I think that goes misunderstood by a lot of people, because I get a lot of comments on my Instagram and a lot on TikTok. So many comments on TikTok that are like, I don't know what you're talking about. My vestibular neuritis has gone on for years. No, the neuritis is gone. The hypofunction is left, and you likely either didn't compensate for whatever reason, or you've developed triple PD or migraine.
Yeah, I think when we think about those like very poster success stories, we're looking at neuritis in a very singular stance. Like they probably got early identification into early rehab. They don't have history that might add some complications to it, or, you know, new diagnoses popping up as a result of it. And that's, you know, the nice textbook looking one, but that's not every day. So then
totally.
That's when we start getting murky.
Yeah. You are the listener, and you are probably thinking, like, is this me? Is this not me? You likely fall into the bell curve of norm. So likely not the person I once saw who came in walking with her shower curtain rod as a cane, and then like 4 days later was like, I feel 100%. That's like one side of the bell curve. And the other side of the bell curve is, this is lasting forever for whatever reason. This is lasting forever. You are likely somewhere in between there. Just statistically, that's what makes sense. And so when you're thinking about this, please do not read all the scary stories in the vestibular support groups and on the internet and on all these places where, like, I know people tell me, I read these stories online and it seems like no one recovers. That is just statistically untrue, but it's sort of like a bad review. Like, someone's going to put one out there that's a negative review, more likely than like, I healed with my neuritis and I never feel dizzy anymore. Like, people aren't saying that. on the internet. They just like move on with their lives. So there are more negative reviews of neuritis on the internet than positive reviews. So I urge you to try and not read them.
Yes. Yeah. Always easier said than done, but
always easier said than done.
Try to do it.
But join us in group, because so many people in group have done phenomenally in group with vestibular neuritis. And there's like whole content pillars and modules and education and the exercises and all the things that you would need to do with neuritis to get better.
Yeah. And if there's maybe a little side twist to your path that involves maybe neuritis plus a little something else, that's a good spot to try to help figure out what that might be.
Absolutely. We will help you with that. All right. Thank you so much for listening today, everyone. We will see you next time.
Yep. Take care.
Bye.